Hello, Dr. Smith and class. My name is Juliet Thornton. I'm a current master's student at Chamberlain University on the NP track, and this is my LACE presentation. LACE, or LACE, stands for Licensing, Accreditation, Certification, and Education. As nurses, we all go through these processes to achieve our certification and licensure as a nurse. We ask ourselves, how does the LACE considerations differ for the 4 advanced practice nurse clinical roles? We have a certified nurse practitioner, which I'm doing. We have a certified nurse midwife, registered nurse anesthetist, it's a fun word to say, and a clinical nurse specialist. In the 3 states that we kind of use to see what's going on with them is California, Washington, and Illinois. For a nurse practitioner in California, of course, you have to have a registered nurse license. You have to have a master's degree or a degree higher, or a clinical degree in nursing. Satisfactory, complete nurse practitioner program approved by the board. You have to be accredited. In Washington, you have to go through the American Academy of Nurse Practitioner certification. You also have to have an active Washington registered nurse license. And then you must be supervised by an ARNP or a physician that is approved and licensed to supervise. In Illinois, of course, you got to go again through the American Nurse Credentialing Center. Of course, you got to have another registered nurse license, and you can only prescribe and dispense controlled substances that your supervising physician can. So you have to have physician supervision. Of course, you have to have a graduate degree in nursing or a clinical advanced practice nurse specialty. For the certified nurse midwife in California, of course, you have to be licensed as a registered nurse, be a graduate of a board-approved program for midwifery. You have to have certification as a nurse midwife by the national or state organization whose the board finds satisfactory. Of course, you used to have a supervising physician in California, but they have repealed that, so you don't have to have supervision. And in Washington, of course, you have to go through the American Midwifery Certification Board. Of course, have an active registered nurse license in the state of Washington with no encumbrance, and you must be supervised by a physician or with the United States jurisdiction. In Illinois, of course, it's the American College of Nurse Midwives, current registered nurse license in Illinois. Of course, again, you have to have physician supervision and can only prescribe and dispense what that physician is allowed to. And of course, you have to have a successful completion of a college graduate degree, master's or higher, in something that's related to nursing. You can't be an auto mechanic and have a nurse practitioner. For a certified registered nurse midwife, for California, of course, you have to go through the Council of the Certification of Nurse Anesthetist and the Council for Recertification for Nurse Anesthetist. Be a licensed registered nurse. I'm kind of seeing a trend here. In all these programs, you have to have your registered nurse license, no matter what you're doing. Of course, you got to have verification from a physician to do any kind of skills and have a clinical competency to perform those skills without direct supervision. And in Washington, the National Board of Certification, Recertification of Nurse Anesthetists. Of course, an active Washington registered nurse license without restrictions or sanctions. And you must have physician supervision that is within the United States jurisdiction. So you have to have somebody looking over your shoulder at all times with these. With a certified registered nurse anesthetist in Illinois, of course, the same as the other two. It's the Council on Certification of the American Association of Nurse Anesthetists. Of course, another registered nurse license in the state of Illinois. Of course, with Illinois, you have to have physician supervision and cannot prescribe or dispense anything controlled substance-wise that the physician cannot. With a clinical nurse specialist, they are a registered nurse with advanced education who pretty much does research, education, consultation, and they are in a leadership position with nursing. In California, they have to be licensed under the Nurse Practice Act with, of course, a registered nurse license. They have to have a master's degree in a clinical field of nursing. In Washington, they are certified by the American Nurses Credentialing Center. Of course, have to have a registered nurse license without sanctions or restrictions. And they must be supervised by a physician, so they can't do anything the physician can't. And in Illinois, the clinical nurse specialists are also certified by the ANCC, and they hold a registered nurse license, and they only can prescribe or dispense what their supervising physician can. So more supervision throughout all three of these states with a clinical nurse specialist, and they must have a graduate degree for a accredited university, and it's within a clinical advanced practice nurse specialty. How many of you here live near states that nurses can practice in multiple states? I live near one. I live in Alabama, and I live near Mississippi, which Mississippi is a compact state. In 2009, they passed several things of the nurse license or compact would allow nurse license to work like a driver's license, and that makes sense. You're certified and licensed to drive on any roadway in the United States. So why wouldn't nursing be different? It's the basic same principles of taking care of patients and seeing their needs. In January of this year, Iowa implemented the Enhanced Nursing Life Compact, which increased access to care, which is one of the big things. Nurses who live near state lines, like I do, they have to have 2 nursing licenses, and that's a lot of fees and training, and every year having to recertify, or every other year, excuse me, having to recertify that license. And instead of being able to practice right there at state lines on both sides with just one license. It also prevents people from working where the work is. Because if there's a shortage in Mississippi and all the people along the state lines are having trouble getting a Mississippi license, it prevents them from going and filling that empty staff spot. So that kind of creates a shortage. And the National State Board of Nursing data will expedite information about disciplinary action and assure protection. That's like the U.S. mail. All U.S. mail goes through. There's no regulations and things that stops it in each state. It just goes. It's a national dispensary. And nursing should be that way, where everything is the same, and you take the same test, and you have the same regulations and rules across state lines. Here's a list of compact states. The ones with the asterisk are pending legislation, except Illinois, and they passed it earlier this month. But New Jersey, New Mexico, North Carolina, Oklahoma. I live near Mississippi, and like all these states I could work in if I lived in Mississippi. That's one of the stipulations. I took my test in Mississippi, my NCLEX, but I reside in Alabama, just about 17 miles over the state line. So that's frustrating when you have to have 2 licenses for a state you're pretty much on the doorstep of. Of course, Mississippi and Tennessee and Kentucky are kind of the lower southern states, but Florida's not on here, Alabama's not on here, Georgia is on here, but they're pending that legislation. So it's kind of up in the air, but it would make sense if everything was all together. That way it'd be more fluid, and it would cost the boards of nursing a lot less. It would all be one lump program instead of 50 or 60 different programs that they have that are certifying nurses. Of course, and also live in Alabama, where nurse practitioners must have physician supervision. I know out in Arizona, in a lot of the western states, nurse practitioners do not have to have physician supervision. They are considered a primary care provider. And that's a problem here in Alabama because anybody over the age of 65, Medicaid and Medicare, are not going to pay as much for non-primary care providers, or what they presume is not a primary care provider. Physicians are the only primary care providers in the state of Alabama. Nurse practitioners are not considered that. And I worked in the ER where we had two sides. We had one that had nurse practitioners and one that had physicians. And we couldn't send anybody over the age of 65 to the nurse practitioner side because they wouldn't reimburse the hospital as much, so we would lose money on that. Now I know in Arizona, nurse practitioners are considered primary care providers, and they are getting the same reimbursement as physicians are for the same exact services. And now as a nurse practitioner with a supervision, you have to be qualified to provide medical direction, or medical proficiency, and are accountable for obtaining enough education and guidance to perform a procedure safely for the patient. And the physician who oversees you must be qualified to provide medical direction for that procedure. As NPs, I know in Mississippi, they work in the emergency room. They pretty much arrange inpatient transfers and admissions, and they do patient notes and detailed narrative and case summaries, and they complete forms pertinent to patients' medical records. And they formulate medical and nursing diagnoses and institute therapy and referrals of patients. Basically exactly what the physicians do. And I think it scares a lot of people away from nurse practitioners, for that single word in front of practitioner is nurse. They assume we can't do anything because we're a nurse. But nurses, they have their own autonomy, and nurse practitioners have a little bit more autonomy in practicing medicine. Nurse practitioners can assess and diagnose medically, where nurses can only do a nursing diagnosis. For example, say if a patient has a broke hip, the nurse practitioner could say patient has broke hip, broke femur related to fall, where a nurse could only say patient has skeletal deformation related to blunt trauma from fall. And that kind of stuff kind of still gets lost in the gray areas because nurse practitioners straddle the line between nurse and physician. We are licensed globally and can do pretty much sutures, and we can't intubate. In Mississippi, I know. In Alabama, I know they can't unless you just have that special certification you have to go through. And we pretty much utilize the same resources the physicians do. We rely on the nurses to give us information, and we perform assessments just like the physician does. So I don't know what the difference is, except just the lack of being able to prescribe, I think, Schedule 2 through 5 and Schedule 3 through 5 controlled substances. With nurse practitioners and nurses, I know it's difficult to see the fine line, but maybe one day with legislation we can be, as nurse practitioners, can be primary care providers in the Alabama or southern state setting. I think it's a matter of time before nurses are fully accepted as a primary care provider, but insurance companies should start be seeing the reasons why there's a shortage of physicians. There's only maybe 1 or 3 primary physicians in a small rural town where there could be 7 or 8 nurse practitioners, and that's all they're able to see. So maybe for the better of the patients, they can be changed into primary care providers. That way insurance will pay more money, and the patients are expecting to get the same kind of care they would from a physician. Well, thank y'all for watching, and I hope to see everyone fulfill their dreams and achieve what their goals are. Thank you very much.